This is an 11-minute webcast for GPs and other health professionals. It features excerpts from a series of talks given by cancer specialists to GPs in Tower Hamlets in 2011. This talk is about upper GI cancer. It's the third part of 4 on this topic. It covers approaches to surgery and complications. The speaker is Francis Hughes, upper GI surgeon and lead clinician for upper GI cancer MDT at Barts Health NHS Trust.
This is a famous person here. This is Mr. Ivor Lewis. That was probably the operation that most of us saw at medical school for esophageal cancers. The surgical techniques have changed a little since Ivor Lewis's day. The operation he described involved a laparotomy to mobilise the stomach and a thoracotomy to remove the esophagus and then do an anastomosis in the upper part of the chest. Nowadays we're using much more minimally invasive techniques, and currently what we're doing at Whitechapel is a laparoscopic gastric mobilisation and then a thoracoscopic assisted with a mini thoracotomy for the removal of the esophagus and the anastomosis. Esophagectomy has had a bad press over the years because of the high mortality and morbidity. If you look at the literature today, the mortality is quoted at around 3 to 14%. The commonest complication is chest infections related to collapsing a lung during the surgery. Cardiac arrhythmias are common. We're operating next to the heart and we do get cardiac arrhythmias commonly afterwards. Thromboembolic complications are common. This seems to have increased in frequency over the last few years. We're unsure whether this is related to the widespread use of neoadjuvant chemotherapy before the operation, or whether it's because of the higher quality CT scans that we're now getting that allows us to identify the pulmonary emboli that perhaps we were not recognising before. Leak from the anastomosis is a very serious complication which is quoted to have a 50% mortality should it develop, and even without a mortality the patient will often have to stay in hospital for several months. Chylothorax is the thoracic duct runs next to the esophagus, and usually we will remove the thoracic duct and tie it off, but chylothorax may occur from the lymphatic vessels causing an effusion. After esophagectomy, then it takes 18 months to 2 years to regain the preoperative quality of life. Patients will continue to lose weight. They often complain of reflux, which is not unexpected because the stomach is high up in the chest. And if they're getting reflux, often they don't describe reflux, but they come with a cough. And the cough is caused by irritation of the vocal cords caused by food that is now high up in their chest rather than below the diaphragm. The treatment for the cough is often not a course of antibiotics. It's something simple like Gaviscon is usually the first line that I would give somebody who comes with a cough after esophagectomy. You can't stop the reflux. Proton pump inhibitors won't work, but the Gaviscon does control it better than most things. The reason that proton pump inhibitors won't work is that running down the esophagus, you will recall, is the vagus nerve, and we've removed the vagus entirely at the time of esophagectomy. So certainly in the early post-operative stages, a proton pump inhibitor is not going to contribute anything because you've denervated all the acid-producing cells. After around about 2 years, new pathways may develop, and it might be worth trying a proton pump inhibitor for patients with persistent reflux type symptoms at that stage. Eating difficulties, I always warn the patients that it's going to be difficult to eat, that they will be needing frequent or small meals, and that this is likely to be lifelong. Some patients come back and say, "Oh, Miss Hughes, you told me rubbish, I can eat a full meal and 3 courses and go out to restaurants," but that is unusual. Most people have to eat the small meals frequently. If they come back with dysphagia, then the most likely cause is a stricture at the anastomosis. And these are easily dealt with endoscopy and dilatation. Patients inevitably will assume straight away that it's their cancer that's come back, but the stricture at the anastomosis usually will come on round about sort of 4 or 5 months, which is an unlikely time, although possible, for a recurrence. So diarrhea, also related to the vagotomy. Patients often require loperamide just for the purposes of if they've got something special and they want to go out, they want to take loperamide beforehand. Dumping syndrome is common, and a lot of patients don't describe the classical symptoms, but they'll come back and they say, "Oh, every time I have something to eat, I have to go and have a lie down afterwards." And then when you sort of question them a little further, they say, "Oh yes, well I do feel a bit dizzy, yes I am a little bit sweaty." Advice for them would be to try and avoid very refined carbohydrates, and if they are going to have very sugary things, then to have some fibre with it, so that that will slow the transit into the small bowel. Metoclopramide. The patients don't complain of nausea, so if you give them metoclopramide, they'll say, "Oh, well, I'm not sick, I'm not feeling sick." But the idea of the metoclopramide is to help the stomach to empty, and by keeping the stomach empty, then it'll improve the appetite. So we often prescribe metoclopramide as a regular medication just for that reason. Some patients are very troubled with bile reflux, and cholestyramine and sucralfate may help with those. From the point of view of follow-up, we see them regularly in the clinic because patients need quite a lot of support through all their eating problems, their pain, their diarrhea, their dumping, all this sort of thing. And I usually see them every 3 months for the first year after the operation, and then go to every 6 months for the next 2, and then an annual follow-up after that.
That concludes this webcast on upper GI cancer. This is part of a series of 10 webcasts available at this address. The Small C campaign aims to improve cancer survival through better public awareness and early diagnosis in East London. You can find out more at this address. And you will find more useful information on these websites.